Hey, good afternoon. So, shall we begin? Are are there more people coming or okay, so let's start. In this class, I'm going to talk about brain stimulation. I will also mention some of the brain imaging techniques, but mainly brain stimulation. So you might be wondering how functional materials, manufacturing, and brain stimulation are related. They are, but not immediately. So the future devices that we um, plan to build or plan to come up with require functional materials, and they need we need to use additive manufacturing to make these functional materials. So we are working on brain stimulation technique, and it's important to understand what is brain stimulation and what we are exactly trying to do and why we need functional materials and additive manufacturing in this field. Um, just out of curiosity, how many of you have come across brain stimulation techniques or treatments? No. So why do you think we need to stimulate brain? What is brain stimulation? Yeah. So, well, stimulation basically meaning increasing the activity in a specific area of the brain. And that is done through several techniques. The one that I work on is by using magnetic fields and magnetic materials. Okay. So, brain stimulation, although it's not quite widely used here in India, um, it has become quite popular in the US. So it will eventually, Nimans uses it, even Ains Delhi uses it. There are lots of researchers who have started to use. Um, so how many of you have heard of ECT, electroconvulsive therapy? Yeah. So yeah, shock, right? Yeah. So um, I'm not sure about epilepsy, but ECT basically you take two electrodes that have current in them, large for the body, not large for the instruments. So you place them one on each side, anesthetize the patient, and turn on the current. The patient convulses. Okay, so that is done for people who are. It's this is an extreme case where people are having suicidal ideation, meaning they're trying to commit suicide, or they're psychotic and they're harming others. Um, Sometimes they use it for epilepsy, but it's for epileptic seizures. There are better techniques nowadays. You can use smaller currents, more focal. You don't have to pump in a large current and make the patient convulse. Okay, so that is called ECT, electroconvulsive therapy. Convulsive is convulsion. And when you administer this treatment, you have to admit the patient to the hospital. There has to be a psychiatrist. There has to be a um, um, who else? Anesthetologist, because you have to administer anesthesia, right? And yeah, it's a full blown procedure. It's like equivalent to surgery. It's a hospital. You have to admit the patient to the hospital, and it's a serious procedure. So that's electroconvulsive therapy. But there are side effects to it. The patient might lose some of the long term memory. Okay. So, and you don't know what, it's not completely understood how it works. It calms down the patient, some of the functions, because you end up, imagine you take a chip and send large current to it, taking the power of the Pentium chip, right? Or I will erase the Pentium chip. Because Pentium chip is so complex. It has a arithmetic logic unit, it has resistors, it has memories, it has all converters. Right? It's a very complex device, and you send a large current to reset it. What do? You burn, you might burn, but you may reset too, right? So you don't know what exactly you're doing. That's what happens when you use ECT, but it has seemed to be working. So if it's a real extreme case, if the patient is committing suicide or is real danger, then you administer ECT. Okay. So, well, now it's obvious. So my next question is, which is the most complex organ in the human body? Brain, obviously, right? So with all other organs, you can represent them as a in a control as a control circuit. Input a function f of x, y equals f of x, and your y is your output. For all other organs, you can do that, but not for, you can't represent brain with one simple function. So brain is a very complex organ. So I'm going to show some of images of the actual brain. So it might look a little, for some people, a little gory, but please bear with me or look away if you don't tolerate. That's our human brain. Okay? That is a 3.5 pounds of pink jelly mass that sits in between your ears, is responsible for who you are, what you represent, your emotions, your memories, everything. Everything you do is from this pink mass. Everything that you do, how you feel the pain, how you feel the emotions, what are your convictions, what are your moral codes, whether you are religious, not religious, whether you, everything comes from that. And I would even go further to say this is the most complex thing in the universe. The reason I say that is, if there is anything more complex than this, if you're thinking that, oh, there is something more complex than my brain, that means you're thinking and comprehending something more complex. That means your brain has to be more complex, right? So um, it is one of the, I mean, it is the complex um, thing in the world, and of course, definitely most complex organ in the human body. So this, you know, when they do surgery to the brain, you don't feel a thing. Do you know why? No pain receptors. So that's why neurosurgeons prefer to do surgery on the brain with the patient awake, so that they're making sure that they're unintentionally not damaging anything else. Yeah. But of course, they anesthetize the patient when they drill through the skull, because skull, skin, these are all have pain receptors. Yeah. But once this is done, the brain itself doesn't have pain receptors. And now, How many neurons do you think an adult human brain has? That's a correct number. Yeah, 85 to 90 billion is the an adult human brain. But if it's a child has slightly more neuron. Children have slightly more neurons, and when you grow up, you establish your connections, you trim others, and an adult human brain has about 85 to 90 billion neurons. How many of you are from biomedical background? Okay, there are a few. Okay, so yeah, so and each neuron connects to 10,000 other neurons. So if you think of the connections, when you can't do straight away permutations and combinations, it will be a huge number, 10,000 and 85 billion, right? But because the neurons from here do not connect to neurons here, so that 10,000 is only to certain number of neurons. So it's not 10,000 to all other neurons. So you can't do the 10,000 C of 85 billion, the combination formula. That will be a huge number. But anyway, if you still do the simple connections or nearby connections, you end up just multiply, right? 10,000 with it. Let's, for simplicity, say 100 billion. 100 billion, 10,000. 10 to the power 4, 10 to the power 10. So you end up having 10 to the power 14 connections. So 10 to the power 14 is larger than the number of stars in our galaxy, right? It's staggering number. So imagine simulating all the connections and all the signal transmission. So, and it's dynamic as well. It doesn't just send one signal and stays like that, right? Keep sending signal. So there is a time series as well. So it's a very complex organ. So can we build an artificial brain? Okay, tell us more. So yeah, yeah. So organoids, okay, there is something called organoids. So you can make smaller versions of your organs with fewer number of cells so that you can study that organ if you supply some drugs or put some drugs on it, or you can do some studies on organoids. But a brain organoid will barely have a million or few 100,000 neurons. You can't have 100 billion neurons in an organoid. And that too, when you have an organoid, connections are not established. Okay? So connections, 10,000, each neuron connecting to 10,000 neurons happens for a period of time. Okay? So it's impossible to replicate such a big number. Okay? So there is a model for a neuron. Hodgkin and Huxley built a model for a neuron way back in 1963. And they got Nobel Prize, I think, in 1966, both Hodgkin and Huxley. So it's basically combinations of some capacitors, diodes, and how the signal integrates from the neuronal membrane and then fires, right? So that's a neuronal firing. So they built a model, but now can you imagine making 10,000 of them and then connecting, sorry, 100 billion of them and connecting each one of them to 10,000 other, it's impossible. It's very difficult to build an artificial brain, not with the current technology. Whatever supercomputers we have can't handle, right? So that is the brain for us. So understanding brain and doing anything with brain is at the frontier of research. Okay, so it's exciting. It's really fascinating to do research in. So now, so how have we dealt with the brain so far? We have ECT and so on and so forth, right? But for a very long time, brain was treated like a chemical organ. So if we wanted to treat any disease, people just gave medicine, drugs. Okay, so there are a class of drugs called selective selective uptake of serotonin. I forgot the full form. SSRIs. Basically, what it does is it's a drug that blocks reuptake of neurotransmitters. Okay, SSRIs. There is a famous brand called Prozac that is prescribed to people who have depression. So a lot of people are having depression nowadays because of, life is complex, so uh, and people also, other diseases have become slightly lesser, so the diseases related to brain are becoming more and more. So the Prozac or SSRIs, I wonder if I've written it somewhere. Okay, so it doesn't matter. So these are the these are the drugs that block the neurotransmitters, the reuptake of neurotransmitters that actually block the firing pattern so that you fire more, your neurons fire more. Okay, so that is used for depression. But so this is the neurotransmitter, and this is a synaptic cleft or a synaptic node where one neuron connects to another neuron. So it's not all electrical. There is no electrical connection. Signal is not going through between two neurons, just like the current that goes through the wire. Neuron stops here. Before connecting it, it releases some chemicals. There are receptors. Receptors take the chemical, and then that signal goes. This neuron takes the signal and makes this neuron fire, and then the signal is transmitted that way. Okay, so now this is a electrochemical phenomena, how the signal is transmitted. When the neurons fire, the signal need neurotransmitters to pass the signal to the next neuron. So, but we have only altered the chemicals here, neurotransmitters here, to get the brain working back in a normal way, such as SSRIs, but we have forgotten the electrical part. Okay, so we can actually, instead of sending the neurotransmitters here, we can actually depolarize this neuron without getting the neurotransmitter and then send the signal. So basically you apply electric field to these neurons and make the signal go. So you can actually just make two neurons communicate just by applying an electric current or magnetic field and make the neurons fire. Okay, so that's what we are going to talk about in this class. So this is what is called as neuromodulation, brain stimulation. Okay, so we make neurons fire without drugs. There are several techniques. Transcranial magnetic stimulation is one technique where I work in, and that uses magnetic fields to apply on the brain make the neurons fire. Electroconvulsive therapy we talked about, and then there is deep brain stimulation, then there is vagus nerve stimulation, transcranial direct current stimulation. These are all different brain stimulation techniques. Okay, so why do we need to stimulate the brain with current or magnetic field? Why not just take drugs, SSRIs? Why not just take medicine? Yeah, side effects. So if you take drugs, first it has to go into your mouth, to your intestine, then into your bloodstream, then wherever the blood goes, the medicine goes everywhere. And well, it does the right thing to the brain, but it might do bad thing to the other part of the body, right? So drugs are not always safe. They have other effects. So yeah, that's why these electrical. But why do we need to? What is the urgency in finding new treatments for the brain? As I said, there are more and more people suffering from neurological and psychiatric disorders. So there is a difference between psychiatric disorder and neurological disorder. Psychiatric means things like depression, anxiety, obsessive compulsive disorder, um, PTSD, whereas neurological means Parkinson's, Alzheimer's, traumatic brain injury. So basically, your biologically some structure has changed with neurological. Psychiatry means if you do a brain imaging, you can't see anything different. It looks like normal brain. Okay? Whereas neurological, you will see some difference, right? So those are psychiatric and neurological diseases. So psychiatric diseases are becoming more and more common because of the complex life, social behavior, and so many worries, busy life, right? So there are psychiatric disorders. People get depressed, people have anxiety issues, people have obsessive compulsive disorder about something, cleanliness mainly, right? And so, and especially when COVID hit, when people were stuck at home, that amplified the psychiatric conditions even more. So, just to give you in terms of numbers, just to give you a picture, in the US alone, there is 1 in 4 people above the age of 18 adults. 1 in 4 adults in the US have some diagnosable psychiatric or neurological condition. Okay? If they don't have now, they had before. They have suffered. 1 in 4. That means US population is 350 million. So more than 80 million people have suffered some psychiatric or neurological condition. That's a staggering number, right? And as and when let me see if my slide has this. Okay, no. So as and when the population age of the mean age of the population increases, right? As and when people start living longer, then there are more and more neurodegenerative diseases. Neurodegenerative diseases are such as Parkinson's, Alzheimer's. They are, you get them because neurons wear out and there is plaque in the brain, and that causes memory loss, movement issues. So more and more people are suffering from neurodegenerative diseases because the mean age of the population is increasing. Okay, and we have better medicine for communicable diseases, we have better hygiene practices, and so on and so forth. So we have taken care of other diseases are still there, but not as serious. We know if we get them what to do, right? So we have them under control. Whereas neurodegenerative diseases, we don't even fully understand how they affect us. Okay, so all over the world, governments are putting a lot of money for brain research. And this is just some numbers here. In the US, National Institute of Health has um, invested about all 4.5 billion, it's about 5 billion now, for brain research. And there is European Human Brain Project as well. Um, and every year there is Japanese Brain Initiative as well. And so is China, and I'm sure India has one too. So just the economic burden of neurological and psychiatric diseases is about 800 billion per year in the US. And that is broken down in numbers. Which disease? Alzheimer's is 243 million. Chronic low back pain because of the spinal cord is 177 billion. Stroke is 110 billion. Traumatic brain injury is 86 billion, and so on and so forth. So you got the idea. So there is a lot of motivation. There is a real urgency to come up with better understanding of the brain, hence better tools to uh, to change the brain imperfections or to treat brain disorders. Okay, so how do you think we image the brain? Excuse me. What are the uh, so for legs and bones we use X-ray, right? What are the ways you MRI, magnetic resonance imaging? Do you know what that is? Magnetic resonance imaging, right? Um, so MRI is one. CT scan, you can have CT scan as well. Um, and there is something called MAG, okay? Uh, MAG is magnetoencephalography. So encephalography means mapping the brain. There is optically pumped magnetometer or OPM mag. So both are, this is still under research. This is very expensive. You need $10 million to set it up. MRI is $1 or $2 million to set up because it has a 3 to 5 Tesla magnetic field in a large size, so that your body can go in. So MRI machine looks like this, your body goes in here. Okay, this is MAG. MAG, you just put your head in like this and the whole machine goes up. This is a superconducting magnet here, and it images your brain. And this is optically pumped magnetometer or OPM mag. And then there is magnetic particle imaging. That's next generation, which is, it hasn't even demonstrated. Okay, so people are still working on the materials and small prototypes on rats and stuff like that. Okay, so these are, and of course the other one is, these are all related to magnetic. Okay, there is of course EEG, which records your brain activity, and it looks something like this, EEG with electrodes, but much simple electrodes, just some coil. It's not like this, it's optic. This is optically, this is optical fiber. Okay, so these are brain images, or sorry, brain imaging techniques. This is magnetic particle imaging. So you have to inject some magnetic nanoparticles into somebody's bloodstream, goes into the brain, then you can image that person. Okay. So even in here, when you are imaging here, sometimes you need to inject contrast agents. These are gadolinium particles that you inject through the brain. They go into the brain, inject into the blood vessels, and they go into brain, and you image with higher resolution. But if you don't need higher resolution, you don't need contrast agent. And contrast agents are discouraged because they have some side effects. Okay. So, I mean, you got an idea, right? There is magnetic particles imaging, next generation imaging technique. So we need new material. So this is how MRI looks like. You get these slices, thousands of slices like this, 2D images, and you stitch them together, and you get a volumetric brain like this. Okay, so this is where we segment it. We take probably the person from Synopsys might have showed you something like this. Did he? ANSYS, Synopsys. Oh, bones and cartilages. Okay, so so what we do is once we get these images, we use what is called as segmenting technique, wherein we look at, we take Fourier transfer of this image and identify edges where the contrast suddenly decreases or increases, and that is our edge. And we separate based on the edge, we separate different structures. So this is ventricles, white matter, gray matter, cerebrospinal fluid, skull, skin. Okay. So this is, we take that and we separate all these. This is imaging techniques. Okay. So once we do that, we have all the, so now that is brain imaging. Now let's come back to brain stimulation. So brain imaging has advanced a lot. Okay. We can image less than half a millimeter, sorry, 0.1 millimeter. We can go to a resolution of 0.1 millimeter. So structurally, we have understood the brain somewhat in detail, if not everything. Okay. Structurally, okay, we have a lot of information, but functionally, how the brain operates, everybody's, structurally also everybody's brain is different, but that's okay. We will just image you and we have the, whatever it is your structure, we have it. But functionally, it's very difficult to understand everybody's state of the brain. Okay. So understanding the functional state of the brain is whole other research. Okay. So that is where you have to measure the oscillations of the brain waves, or the firing of the neurons come as waves. So you record them, and you know that, okay, that part of your brain is more active. That means you're afraid of something. That part of your brain is more active. That means it's a pleasure center. Oh, you are feeling happy about something. Okay. Oh, that part of your brain is more active. That is, oh, your heart rate is going up. So we can that is how the functional imaging of the brain is done, but in it's very difficult to know all the functional state of the brain, right? So now let's come back to the stimulation. So when we stimulate, we change the functional state of the brain. And structure, we may change over prolonged period of stimulation, but we want to change the functional state, right? So brain stimulation is nothing new. It existed since, BC's Greeks time, when they were using this uh, torpedo fish to put it, gives a small electric current. They used to put on their head to relieve their headaches. Okay, So that is nothing but kind of brain stimulation. And there were different people, but the most notable one is where is Galvani? Yeah, Luigi Galvani's animal electricity. When he put the current on the frog's uh, spinal cord, and he was able to stimulate the frog's leg. So Luigi Galvani coined the term called animal electricity, right? So he said there is an animal electricity. And then a lot of work went in afterwards. After Luigi Galvani discovered this, there were so many people opposing it, so many people in favor, and eventually people started to develop different things about electric current, and there a lot of work went in. But then the other notable one is Wilder Penfield's work. So what he did was, he's a neurosurgeon. He was identifying which part of the brain is responsible for which part of the body. So he was taking small current to stimulate certain part of the brain, so that this is when he was trying to cut off certain brain mass in cancer patients or something like that. And he used to test different parts of the brain whether they're working or not. And to test, he used to send small current. And while doing so, he was able to see different uh, parts of the body moving when he stimulated different part of the brain. So he developed a map called homunculus map, which became very popular. So you can literally, on motor cortex, you can stimulate one area to the other, and you can engage different muscles. Okay? And then comes Hodgkin and Huxley, who built a model of a neuron. Okay? So it's all the way until recently. So you have so many techniques on brain stimulation itself. Okay? So what about, has anybody heard of Neuralink? Others? Has anybody heard of Elon Musk? Yeah, it's his company, Neuralink. So yeah, Neuralink is a chip basically. Okay, he implants. So please go and check. It's amazing how Neuralink works. But having said that, Neuralink is nothing new. Neuralink, there were other chips. There is a chip called Utah chip, a um, electrophysiologist from Utah has developed a chip called Utah chip. And then there was a Michigan chip. This is way back in 1990s. And they actually were able to implant these chips on motor cortex and record all the signals coming from motor cortex, and use those signals to control robotic arms or wheelchairs, so that when a person is quadriplegic, meaning he can't move any of his or her limbs, he's stuck in wheelchair, then what do? You put these Utah or Michigan chip and collect the signal and send them to the wheelchair, so the person can just think about moving forward, moving left, moving right. Actually, that is one of the project in our lab right now in VCU. We are actually recording, not with chip, but we are recording EEG signals, and using machine learning, we are extracting only the part of the signal that is responsible for motor cortex thinking of forward motion, left motion, right motion, and backward motion. And we are connecting these classified information into a robot. So this is a autonomous robot that goes. And so a person will wear a EEG cap, and they just think moving forward or moving backward or moving left or moving right. This is actually a final year project in my lab. We are actually doing that right now. So robot will go left, right, and even we The robot also has a 6 degrees of freedom arm that actually takes signal from the muscles, triceps, biceps, and these thumb muscles to, yeah, non-invasive EEG. Yeah, EEG is just a cap. Yeah, that. Um, yeah, yeah. So it's not easy to work with EEG because imagine, so neurons are firing and each of your electrodes are recording these signals. And what does it mean? How do you know that the neuron signal that's coming from some area of the brain means something? Okay. Yeah. Yeah. So that's $1 million question. So if you can decode the signal, different software, we are using machine learn to basically classify these signals into 4 categories, which is very simple: forward, backward, left, right. So, but imagine, so that we collect all the information, thousands of seconds information, and just to decide whether we are thinking about forward, left, right, or back. Can you imagine if you want to decode memories, decode emotions? It becomes even more complex. Okay. So anyway, long story short, yeah, Neuralink. So Neuralink, um, the chips existed before. Neuralink, please go and look up. You will be amazed how Neuralink is basically industrializing these existing chips. They are able to make a nice single chip that has a battery pack, and it also can communicate wirelessly between external devices. But whereas Utah and Michigan chip had to be hooked up with a wire, and you could see it looked very ugly when a person has some protruding electrode coming out of the head and connected to wheelchair. But that's how the research happened. Okay, but Neuralink looks so smooth. You don't even know whether the person has that chip or not. So it's that nice, and they have already tested on few human subjects. Okay, so, and it uses machine learning. It uses a robot to send these electrodes into right neurons within motor cortex, but it only does recording right now. It doesn't stimulate. Okay, so we are talking about stimulation, meaning recording is easy. I mean, easy, but deciphering it is, or decoding is hard, but recording is easy. Okay, um, but stimulating the brain is even harder, and it's not safe. Government will not allow you to come up with a device just like that to stimulate certain part of the brain unless you tell what exactly it does, how it helps, does it cure any disease, and so on and so forth. Okay, so that is brain stimulation. So there are non-invasive stimulation devices. TMS is one of them. There are invasive stimulation devices. Non-invasive ones are just sit on the brain and send some signal or magnetic field. Non-invasive ones need to be put in the below the skull surgically. So they have risk associated with them. You need hospitalization. You do it only when there is clear understanding that this works, this treats this disease. And there you have some freedom to test it, and because all you can do is non-invasively, right? Send some signal. If it's not working for a few minutes, take it out. Okay, here are different stimulation devices. This is ECT, electroconvulsive therapy, TDCS, TMS. This is a magnetic coil. This just TDCS is just puts a 9-volt battery, and it's a very small current of milliamps. And that small current doesn't make the neurons fire, but it changes the oscillating patterns. Okay, So this is not a very robust stimulation device because it works with sub-threshold uh, currents. This sends a large magnetic field to a focal area and makes the neurons below that coil to fire, and thus making them active. Then we have invasive deep brain stimulator that I asked you to look up. This is routinely used for treating Parkinson's patients. And the battery pack continuously sends signal in subthalamic nucleus to make dopaminergic neurons to fire. Okay. Then here is other uh, devices not so popular, but those are the top three. ECT is more very widely used, especially in Asia. In India, this is quite widely used as well. And these are other popular ones, and that DBS is used for Parkinson's. Okay, here is TMS started as a party trick. This is Reza Jalinas, um, Anthony Barker, Tony Barker, and Reza Jalinas. These are electrical engineers. They built first commercial stimulator. They used to use it as a party trick, just to put it on the brain and then make people's hand flip like this. And it was so interesting that there used to be line in front of their office in University of Sheffield, UK. So it started as a party trick, but then they started to see that this was, I mean, it's not, it was easy to connect because they were already looking at ECT, how it was reducing depression. So they tried it to treat depression, and it worked. And now it's quite widely used for treating depression. So how does it work? TMS, transcranial magnetic stimulation. So basically, the magnetic coil, it has just copper windings. Yeah, you send a large current. The current amplitude is 5,000 amps, but it's a very short pulse for a very short time, which is 0.4 milliseconds. You send that large current in this coil, it generates a large magnetic field. That magnetic field is AC magnetic field, meaning time-varying magnetic field. So what happens if you have a time-varying magnetic field? By Faraday's law of induction, if you take a time-varying magnetic field and put it on any conducting material, the conducting material will have some current. So if we put it on our head, what is the conducting material in our head? Neurons. CSF is also conducting, but it doesn't do anything. But neurons are also conducting, so the neurons will fire. So this is the Maxwell's equation, which says del cross E equals minus dV by dt. So time-varying magnetic field, B, gives you a circular rotating curl electric fields. Okay? So if you put it on a neuronal membrane, how it works is neuronal membrane, if you look at a neuron has a soma, cell body, and it has an axon, right, for transmitting. The cell body, and even the axon, the cell membrane maintains from inside to outside, it maintains a potential difference. It maintains a voltage difference. So the potential difference between the inside of the cell and the outside of the cell is minus 70 millivolts. So that is the resting potential of neuronal membrane. And it always stays like that, but when it fires, so if you decrease this potential to minus 55, then it starts to fire. So that is the threshold field, threshold potential to make a neuron fire. So how does the firing happen? The membrane has ion channels, so the ions move in and out. So when it's it reaches an equilibrium, it stays at minus 70 millivolts. And when something happens, the membrane allows some ions to go inside, then you have smaller potential. And then it realizes that it has to open up all ion channels. So all the ion channels are open, and a current goes in through the soma and into the axon and to the other neurons. Okay, so that's how a, a neuron fires. Okay, so that means if we can go from minus 70 resting potential to minus 55, we can make the neurons fire. So we have to get that minus 15 millivolts electric field using this magnetic field on the membrane so that we can make the neurons fire. And that's what we do. Okay, so we get current sufficient to get that threshold potential to make neurons fire. That's how TMS work. So, and this is how it looks like, a coil. This is just copper windings, and it's placed on somebody's head. And the coils look like this. This is used for 1 hour long stimulation because it needs to be cooled. When you do it for 1 hour or 45 minutes, it heats up a little, so you need some cooling fan here. This one is laboratory grade, so you don't need 1 hour stimulation. So it's a FDA approved technique. It's quite widely used. It's used for depression. So if you do it for 45 minutes, 5 days a week, for 2 months on left dorsolateral prefrontal cortex, basically a motion part of the brain. If you do that, then you introduce permanent changes in that part of the brain. So the neurons, if they're firing at a lower rate before, now they come back to healthy firing rate. Okay, so that is um, the effect of that long-term stimulation. So it's called neuroplasticity. So the neurons are basically getting trained to fire to a healthy level. Okay, so so far there is no side effects reported, and it's also reversible. So um, we so if you don't stimulate right on the left dorsolateral prefrontal cortex, if you move away and hit the trigemin, I forgot the name of the nerve, trigeminal nerve that goes to the face, you can have headaches or twitching of the face. But other than that, no other side effects reported. Well, if somebody has a history of seizures, you can introduce a seizure to that person. When you do it, not just any stimulation parameter, but prolonged stimulation with high intensity, you can introduce. Um, there are so many diseases that are FDA approved: depression, obsessive compulsive disorder, smoking cessation, and migraine as well. So each of them, so for depression treatment, there are several companies: Neuronetics, MagStim, BrainsWay, and MagVenture. For migraine, there is only one company called eNeura that treats migraine with brain stimulation, TMS. OCD, BrainsWay. Okay, so how do you determine, like, how can, what changes if you have to treat different disorder? What do you need to change? Yeah, position, because different disorders originate from different area of the brain. Parkinson's comes from deep within the brain. Depression comes from your executive emotional part of the brain. If you have schizophrenia, it comes from primary auditory cortex, right? You are hearing hallucinations, right? Auditory voice. So that comes from auditory cortex, right? So different areas of the brain treat different diseases. are different are responsible for different diseases. So if you want to treat those diseases, you have to position the coil in different location or target different group of neurons. So the other drawback is the brain has a lot of neuroplasticity. So what that means is, if you if one part of the brain is not working properly, the other part of the brain overtakes its function. Okay, so if you try to overstimulate stimulate activate one part of the brain, it might reduce the other part. So it's not just one region of the brain, it's the whole network, neuronal network, that you have to target, which means you have to stimulate multiple regions of the brain. Okay, here is a video. Um,
If we start at the back of the brain, we've switched off my visual cortex, so made me unable to see things. If we move a little bit forward in the brain, we've interfered with people's ability and my ability to see faces. A little bit further forward, we've interfered with the ability to perform actions. Start moving your finger. It's quite odd. It's not your finger anymore. It's not my finger anymore. We've interfered with the ability to compute with numbers. 6, 7, 8. Okay. Ooh, yeah. Yes. We've interfered with the ability to speak. London Bridge, London Bridge, London Bridge is falling down. You think of something you can do, and we've basically interfered with it with this machine. 2, 3, 4, 5, 6, 7, 8. So what's the problem? I don't know.
So yeah, that's a BBC 4 documentary. That is Michael Mosley. His Cell documentary is another one that's really amazing. But anyway, so we still need it. So here is homunculus. I showed about different area of the brain controls different part of the human body. So here in this lab, so our TMS labs usually look something like this. Okay, we have some oscilloscopes to measure MEG, motor work potentials. We have TMS device, and that's a MagVenture TMS device there. And we have these reflectors that are tracked by a neuronavigation system, but not all of them need to have those reflectors.
Hi Recon, welcome to our laboratory. Today we're going to show you how the transcranial magnetic stimulator works. So first thing, Yoshi's going to put the magnetic coil over top of the area of my motor cortex that's responsible for the muscles of my hand and forearm. Once she's there, she's going to deliver a magnetic pulse. Oh, and you probably saw my arm twitch there. And we can also see this response over here on the oscilloscope because we've measured it using the EMG electrodes over the muscles of my hand and forearm. Now what we're going to do is move that magnetic coil over the span of my motor cortex from one side all the way over to the next. And what you'll see is muscles slowly recruited from my hand up to my elbow, shoulder, right leg. And after she switches hemispheres, we'll see some of the left leg come in and then down the muscles of my left arm. So here we go. So right hand, little bit of elbow.
So notice that she's doing it here, and the effect is happening on this side. Okay, so your right part of the brain controls left side of the body, and left part of the brain controls right side of the body. Okay.
Some shoulder and leg. Still right leg. Little response in my left leg there. We've switched hemispheres. More leg on the left side. Left shoulder. Left elbow. And left hand. Thanks for joining us.
Okay, So that's just showing how you go from one side to other side. You can recruit finger to elbow to shoulder to this side, I mean leg to this side. Okay. Now, how it is used for treatment.
The problem we're trying to solve in stroke is to help people have a higher recovery of hand function. The brain has been damaged by the stroke. We're trying to help those neurons that have been spared by the stroke, but have become dysfunctional from disuse. Repetitive transcranial magnetic stimulation is a way to stimulate the brain without surgery. This device stimulates the brain cells painlessly. There's no pain at all. We can change the excitability of these neurons so that they can be activated more easily by the person voluntarily. The patient walks into the clinic, and we make some measurements of the head to find the best place to put this stimulator on the head. Then we apply stimulus, and we might get a contraction in the opposite hand. It won't hurt, but it could move just because the stimulation activates neurons in the brain that in turn go to the spinal cord and in turn go to the muscle. But then we turn the stimulation down to a lower intensity because our stimulation really is intended to be sub-threshold, that is below the level that produces a muscle contraction. And by doing it repeatedly, we hope to change the excitability of the brain to make it easier for the person to do it on their own.
Okay.
After the brain stimulation,
So basically, if a person has a stroke, one part of the brain area is dead, so the other part of the brain area is still active, but it doesn't normally do the motor function. So you activate it to make the motor function. So that's what they are trying to do, but it's still, I mean, the results are not very straightforward because it's not easy to say, okay, this group of neurons are responsible for this. This is how much I need to stimulate in order to make it happen. It's also the time dependent effect. So whether I'm doing it right for 30 days or it should go on for 90 days. So there is so many questions that are not answered. Okay. So now what we do, what my lab does is come up with magnetic coils. If you saw one common theme in all those videos was the coil is just this figure of 8 simple coil, right? So if you want to move around, I mean, if you want to target different area of the brain, you have to have more complex coils. And you have to have different strength of the field in order to target different areas of the brain. Did you have a question? Those are the studies that we are, I mean, I'm collaborating with somebody who is working on addiction, opioid addiction. So yes, alcohol, opioid, gambling addiction, all these are still, but which area of the brain you want to target, with what strength, whether it is for how long, can you maintain the network, can you tune the network and leave a permanent change? So that's still yet to explore. Yeah. So, so we need to come up with new coils that can stimulate different areas, and people are just using one coil in one location. But we know that neuronal network, it will compensate if you just do it in one network. You might have to stimulate simultaneously in two areas, right? So those coils do not exist. So in our lab, we are coming up with new kind of coils that can target different disorders, not just Parkinson, not just depression or smoking cessation or OCD. So this is a study quite widely cited. To me, it's a it's treating brain as a ball, which I completely disagree with. But their claim is that doesn't matter. We are looking at the efficiency of the coils here, and coil efficiency can be seen with a simple geometry. It doesn't need an actual brain. But I disagree because the electric field propagates in a way which depends on the contour of the brain and also orientation of neurons. Now it is well established. But when this was published in a very prestigious journal called Brain Stimulation, if I would have reviewed it, I would have rejected it. But just the people were from very famous university, they published it. At the same time, we were working on coils and we were using the heterogeneous heads that were built from MRI images. Okay, so how are we doing with time? We have another 15 minutes. So again, briefly, electroconvulsive therapy, large current, one electrode, another electrode, and I talked about how it is not very safe, but it has been effective for serious conditions. So it has to be done in a hospital setting. The person has to be anesthetized to do that. And then is the deep brain stimulation, which is an invasive procedure. So a DBS lead goes from the skull all the way to subthalamic nucleus, STN, okay? And it continuously stimulates that area through a battery pack that is again implanted right below the skin here, okay? The leads, wires come below the skin, okay? It looks, for people who haven't seen many surgeries, it looks somewhat really crude and not pleasant. But for people who get this, it's a life-changing event, right? It's completely, they get their life back. So of course it's risky. You have a hole in your brain, in your skull, which is not, something you should be. There is chance of infection, re-injury, and so on and so forth. They can't play serious sports because that can get dislodged and so on and so forth. There are risks associated with this, but it's a reliable treatment procedure for treating Parkinson's. Okay, here is a video that shows how the Parkinson's patient is happy about it.
Today is the 13th of November, 2010. 1 year ago on this date, I was in the operating room at Stanford Medical Center for Deep Brain Stimulation Surgery, or DBS. An implanted pulse generator, or IPG, was surgically placed just below my right collarbone and is hardwired under the skin up to the two entry points at the top of my head. When it's on, the tremor is optimized. There's virtually no tremor in my right hand. By turning it off with a remote control, you'll see what my condition would be without the DBS. The first two attempts to push the correct button failed, but the third attempt worked. The stimulator is now off. Within seconds, you'll see the tremor return. My tremor is a resting tremor, which means when I initiate action with my right hand, the tremor dissipates. When the action stops, the tremor returns. Another visible symptom of Parkinson's is the inability to walk normally. With the stimulator turned off, my body is stiff and I shuffle when I walk. Turning around is difficult and my balance is poor. I don't dare try to hold a cup of hot coffee right now. I don't think you can see it, but close up you notice that my face has dropped significantly. I can really feel that at this point.
I want to turn the IPT back on now, but I need to put it in my left hand. My right hand would be banging against my chest too much. Within seconds of switching it on, the tremor subsides and virtually disappears. I don't turn the stimulator off very often, but it is definitely an attitude check when I'm feeling frustrated or depressed. Thank God I live in a time for this kind of technology.
So it's not just the tremor, they also can't immediately turn like this, or their body is so stiff. If they sit down, they can't get up, or if they're standing, they can't sit down. So everything, my advisor has Parkinson's, and it's a neurodegenerative, meaning it sets on very early and you don't notice it, but then it takes a long time to make you immobile. It literally makes you immobile. Okay, so yeah, I've seen some really tricky moments when we were in a conference. It was but anyway, so in a short story, it's very highly debilitating disease. So you don't have smell, you don't get sleep, lots of issues with Parkinson's. So once you implant this DBS lead and continuously stimulate, it's immediate effect. Okay, that's because we know the motor pathway circuit and we don't know how it works. The continuous stimulation in subthalamic nucleus is helping the dopaminergic neurons to be active. But nevertheless, it works. So we did a computational study on that as well. So so the neurosurgeon in VCU, she does 2 such surgeries a week, Wednesday and Friday. Yeah, so she claims that she has done 1,000 such surgeries. Okay, and she has patients who are 15 years, we had this one 10, 15 years ago, and now it's a neurodegenerative disease, so it progressively becomes bad and bad. So somehow now speech problem or swallowing problem, mouth motor area has issues. Mouth motor area means it's motor area which is on cortex, not deep within. So your DBS lead can't do anything to the mouth motor area. So she wanted to use TMS to treat mouth motor swallowing issues, speaking issues. But then TMS, high magnetic field, DBS lead, small current. There will be electromagnetic interference between DBS and TMS. So she asked me to do some computational study whether it's safe or not. So we did that. We had to build accurate models of the DBS leads. You see each one of them is connected to one wire, and when it comes here, there are 4 wires wound in a spring fashion. So just the lead itself was 2 gigabytes. So we did a very high resolution model, built this model, and then of course we took her patients MRI, built a head model, and she told us where is the location. We used that location, put this lead, and started putting TMS coil in different locations to see where it is safe, where it's not safe. Okay? So we also looked at what happens to temperature change. Of course, this is governed by a complex equation here, which I keep it behind. So yeah, and again, E field we look at is governed by Maxwell's equation. So so we concluded that if you use a TMS coil and go right on top of the lead, you generate induced electric fields in the lead equivalent to how much you use it for stimulation. So that means it can interfere, right? So if you go, whereas on mouth motor area, if you use TMS, the DBS leads are slightly far away, you are not affecting it. Okay, that's our conclusion. So this is TDCS. TDCS is becoming popular as well. Too many videos. So let's do this one instead.
What if becoming an expert pilot were as simple as putting on a cap?
So our system is one of the first of its kind. It's a brain stimulation system. It sounds kind of sci-fi, but there's large scientific basis for the development of our system. The specific task we were looking at is piloting an aircraft, which requires a synergy of both cognitive and motor performance. When you learn something, your brain physically changes. Connections are made and strengthened in a process called neuroplasticity. And it turns out that certain functions of the brain, like speech and memory, are located within very specific regions of the brain, about the size of your pinky. What our system does is actually target those changes to specific regions in the brain as you learn. The method itself is actually quite old. In fact, the ancient Egyptians 4,000 years ago used electric fish to stimulate and reduce pain in certain areas of their head. Even Ben Franklin applied currents to his head, but the rigorous scientific investigation of these methods really started in about the early 2000s. And we're building off that research to target and personalize the stimulation in the most effective way possible. Your brain is going to be very different than my brain when we perform a task. And what we found is that in specific circumstances, the brain stimulation seems to be particularly effective at actually improving learning.
One of the aspects of learning we're most interested in is how the expert brain functions. Part of what we wanted to do when we invited expert pilots to perform our experiment with us was that we wanted to better understand what their brains look like as they're performing this very particular training that we've set up. We were hoping to modulate the brains of novice pilots who had never seen this task before in order to try to make their brain states more similar to the experts.
What that means is essentially we were able to take a group of individuals and train them to a similar level than we could without the brain stimulation. The method employed of brain stimulation relies on actual physical contact with the scalp, a head cap through conductive gel to apply the currents to the skin or the scalp of the head. It combines three modes of imaging and stimulation. One is called functional near-infrared spectroscopy. This measures the blood flow changes within the brain. The other is called electroencephalogram, EEG. This measures electrical potentials at the scalp that are indicative of brain activity within that location. And the third modality is the actual stimulation paradigm, where we can turn on or off certain regions of the brain and actually image that process in real time with those other two modalities. The idea there is to actually visualize the changes in the brain that we're inducing and that are occurring naturally. And this is kind of a way to target or personalize or adapt the stimulation to the individual in real time. What works for you as a novice might not be the same paradigm that works for the expert. The actual neurological effects can persist for hours. Those effects take days or weeks and practice to consolidate. It's the same learning mechanism. We're just amplifying it or boosting it with the stimulation.
The study showed that novice pilots demonstrated a 33% increase in skill consistency compared to those who received the sham stimulation.
Neurostimulation technology is, I consider it to still be in its infancy.
Current technology uses a simpler, non-custom interface to connect with the brain. The system designed by HRL allows for customization of the stimulation, which is key.
The field in general is very new. As we understand more about the brain and the technology that we're working with, we'll be able to better help people, whether that be in training, in learning new skills, or improving their performance, or whether they've had a traumatic brain injury or a stroke, some disease or pathology that prevents them from having full function over their faculties. Whether we can use this technology to help those people and to help people that are simply looking to improve their performance is a question for the future and something that we're working on very closely now.
Okay, so there are studies where with even TMS also you can improve mathematical ability. So there is one study from Australia where they have shown that by stimulating, I don't remember the exact region of the brain, but by stimulating that region of the brain, you can increase the mathematical operations, whatever you do, like multiplication, subtraction, and addition. It has improved, that ability has improved. So there are many studies like that. That one was for improving the flying of an airplane, 33% increase they established. Again, this is without the knowledge of knowing exact the circuitry, but if you know the exact circuitry, and if you target, like Parkinson's is very well studied. So the DBS leads, it goes to the right place, stimulates the right circuit, works immediately, right? That's not possible with the non-invasive techniques, but that's where we want to go. That's our motivation too. So we want to use TMS to get the effects like DBS, okay? So this is another technique called vagus nerve stimulation. So this stimulates a nerve that comes out of the brain that goes to the vagus nerve that is responsible for many things. It is responsible for immunity. It's responsible for so many other things. So it has shown to work for treating depression as well. So it's not as popular as other techniques, but there are other new, this is new technique that VCU is working on. This is a video from VCU. I want to show this, and you can see the neurosurgeon who I work with.
I had them for 30 years, but I didn't even know it. And in the fire department, we had to have a physical every year. It's mandatory. And the doctor told me, looked at me, you got essential tremors. I said, what's that? I don't think I'd ever heard of them at that time.
I actually met Ross a few years before we did the procedure. And he had been referred because he had tremor that was bothersome to him. Patient typically has essential tremor, which is a hereditary disease. But it starts out as a minor tremor that just progresses over time, and it can come to interfere with all their activities of daily living.
Every year it got worse. I couldn't do hardly nothing before. I was just, like that all the time, both hands. I shook so bad that I couldn't hardly function.
We have these people come in, sit down and talk to us. We look at how their tremor affects their lives. We see how severe it is. And then we talk to them about their options. So if the patient is not responding to the medication, then we consider a surgical procedure. And focused ultrasound is one of those procedures.
And focused ultrasound is a combination of new technologies to do the old procedure. So we're still creating a lesion in the brain, but we're doing it in a safer and more accurate way. The way that this works is that there are about 1,000 different individual sources of ultrasound energy. And they all travel and meet together at one point, kind of like if you hold a magnifying glass over a leaf and you can burn a very specific spot. Similarly, no one of those individual ultrasound energy beams has enough energy to cause any damage. But when they all meet together at that one point, enough energy adds together to create a lesion.
So I knew that this would be a good choice for him because the tremor had gotten worse.
So it is an outpatient procedure, and we do it with the patient awake in the scanner. So there's no need for general anesthesia.
The first thing you do is cut all your hair off. I got back problems. They took care of me. They patted my back down to where I didn't feel a thing through the whole procedure.
What makes focused ultrasound sort of more instantaneously gratifying is how immediately we see the effects.
Everything went perfect. They about every 30 minutes, they'd hand me a pad and a pencil and tell me to do a circle. And the first time I was coming over the pad, I couldn't even make a half a circle. And about another 30 minutes, they handed it to me, and everybody in there applauded because I made a perfect little circle like they wanted.
So again, this is they showed up in the morning. You know, several hours later, their tremor is significantly better.
It's really that team approach and that very careful approach that we take. We are really dedicated to making this the best, safest procedure possible for the patient.
When they took me out, I was so excited. When she came down the hall, I grabbed her, hugged her to death. I told her, I said, "You give me my life back." And in a sense, she did. It's amazing, totally amazing. I go to the gym 3 times a week, even now. I can go an hour on a treadmill. I refuse to stop. But I'm a nut at it. I've been doing it for 25 years, and I ain't gonna quit till I can't move. I'll quit.
So that's focused ultrasound. That's a new procedure that started in VCU. VCU is not. So Paul Koch and Catherine Holloway, they are my collaborators. They did not invent it. It's done by another person called Ali Reza. So he's from West Virginia University, he was at Harvard. So they collaborated with him, and now they have brought this procedure to VCU. So it's amazing how, although that worked, but we still want to use magnetic coils to do the same thing. But here, with that one, with that procedure, they're still using ultrasound and burning certain area of the brain. So it's still irreversible procedure. All these ultrasound waves go and burn a small area. And it's a permanent procedure. If you want to go back to original state, you can't with ultrasound. Whereas we want to use magnetics, and if you want to go back, you should be able to go back. Okay? So now, the physics doesn't allow us to stimulate deeper structures like ultrasound. Ultrasound has clean, narrow waves that can go and meet at a point, whereas magnetic fields don't have that luxury. Okay, lasers can go and meet at a point. Magnetic fields, you can't focalize them. Okay, they disperse. So that is the limiting factor. So what's the solution? Of course, everybody wants to know. I mean, so we have certain ideas which we are working on. Of course, they involve magnetic nanoparticles, which means another functional materials, which means we have to put these particles inside the body so they will make the flux lines focus to a certain point. So that's the idea, and we are still working on these core shell magnetoelectric nanoparticles. I think we are 7 minutes. So can I take just 1 more minute? This guy is another famous guy from Rice University, has a degree in Harvard, came up with magnetoelectric materials, which we have been working. But anyway, but he explains, because he's famous. So he talks about—
in my lab, we looked at lots of different things to try to do this. And one day I was in my office and I got a manuscript to review that proposed to use these magnetoelectric nanoparticles. And this is kind of embarrassing. I was looking at that manuscript. I'm like, that is like not a word. I studied physics at Harvard. There's magnetism and there's electricity and this like that. You just made that up. And I'm going to get you because I'm doing peer review. And as I was going through that manuscript, actually, I was wrong. This is like a real material. But it was really interesting because I was like, oh, I haven't heard of this before. Maybe there's something interesting here. What was the reason why I hadn't heard of it was that it's an incredibly rare material. So most materials either have magnetic polarizability or they have electric polarizability, usually not both. And in fact, there's almost no natural materials that have both of those properties. But the ones that do are called magnetoelectrics. And I want to show you how that works and then why that led to the breakthrough that allowed us to build it. I'll show you in a minute. So the way that we create these materials in my lab and now in my company is we take two different materials. One is a magnetostrictive material, so it has the magnetic properties. The other is the piezoelectric material, it has the electric properties. The magnetostrictive material, it vibrates when I turn on an alternating magnetic field. The piezoelectric material, as you're probably more familiar with, creates an electric field when it vibrates. And so we can combine these two things together. I can apply an alternating magnetic field transferred into mechanical energy, which then creates an alternating voltage. We use magnetic induction for the wireless power plantable medical device today is recharged using magnetic.
So you got the idea, right? So there is a piezoelectric at the bottom. On top, you have a magnetostrictive material. Apply magnetic field, magnetostrictive material oscillates, that creates piezoelectric oscillations. If piezoelectric material oscillates, what happens? Generates a voltage, right? And that voltage can be used. So if you have a nanoparticle and you have a core shell where the core is magnetostrictive material and shell is piezoelectric material, okay? So you apply magnetic field outside the head and make the core oscillate, right? That makes the shell oscillate, but shell is piezoelectric, and when the shell oscillates, it generates voltage. And if these nanoparticles are sitting on the neuronal membrane, they generate voltage to make the neurons fire, right? So that's the idea. But to make that happen, it takes first of all, we have to get a core shell nanoparticle that is of the right property, which we are still working on, okay? So anyway, that's where brain stimulation to magnetic nanoparticles. You see how it ends up to the materials. When things get hard, what do? You go to materials, right? So now we have reached everything. So now we are looking at new materials so that we can come up with or solve the challenge of stimulating deeper but more focal. Right? Any questions? No? Oh, there was so much information. How can you not have questions? Okay, so I'll be around. I don't want to hold you back from your coffee break. So if you have any questions, I'm happy to answer.